Good morning, everyone. So today we'll discuss the epidemiology, pathophysiology, and clinical features of coronary artery disease. So first, coming to the definitions, all terminologies CAD, CSD, CBD, are they all same or there is something different in them? So CAD refers to atherosclerotic process affecting the coronary artery disease. And whereas coronary heart disease include the process of CAD which leads to either angina, myocardial infarction, silent myocardial infarction, they all are included in coronary heart disease. So coronary heart disease is basically a manifestation of coronary artery disease. So what does CVD means? CVD is cardiovascular disease, refer to atherosclerotic process affecting the entire arterial circulation. It is just not confined only to the coronaries, it is also confined to the cerebral circulation, which can lead to stroke, TIAs. In the coronaries, it can lead to angina, myocardial infarction. In the peripheral circulation, it can lead to claudication, critical limb ischemia, and other manifestations. So, what is the epidemiology of the coronary artery disease? So the numbers are very surprising, and these numbers are from the American Heart Association, and this is a relatively a 2-year-old data which shows that there are almost 1 million people who will have a MI or heart attack or will die from coronary artery disease in this year. 1 million is a huge number. 16.5 million are living with coronary artery disease. Almost 8 lakh people will have a stroke in this year. 3.5 lakhs will have cardiac arrest or they'll be resuscitated from cardiac arrest. The number of diabetics will be 23 million, and more than 50 million people are eligible for lipid lowering drugs, that are statins. And 38% of the population will fall in the category of obesity. And the number of hypertensives will be more than 100 million. So coming to epidemiology of CAD in our country, the prevalence is quite high when we go down the south and some part of central India and in North India. And it relatively decreases when we go to the eastern India. But it is very high in metro cities and in South India, maybe because of the prevalence of diabetes and other risk factors. So some epidemiological facts. The prevalence of CAD in India is quite high, 23.8 million people, and which has increased almost 2.5 times from last 3 decades, 2.5 decades. It accounts for almost 20% of the total global CV deaths. In the age group of 30 to 69, almost 1 million deaths are caused by CAD. We have a significant male preponderance for CAD, but the preponderance is neutral for the stroke. The prevalence increases with age both for men and women, and the prevalence has been increasing gradient from the low to high income states, with highest prevalence in Kerala. And 17.8% of the global population has been affected with CAD, with a daily loss of almost 23% in our country. So some facts from the Framingham Heart Study, which is a very old study. At the age of 40 years, the lifetime risk of CAD is almost 49% in men. And the incidence rises steeply with age, with women lagging behind men by a decade. In serious manifestations, the women lag behind men from almost 2 decades. but the sex ratio almost balances and narrows with the advancing age. In premenopausal women, the serious manifestations of CAD such as MI and sudden death are relatively rare. And beyond menopause, the disease increases almost 3 times. So the protective effect goes off once the female attains menopause. The initial presentation, males predominates in all ages, and only 20% have angina previous to any myocardial infarction. In females, angina is quite more common as compared to males, and they are more likely to present with angina. The death rate is higher in men as compared to women, 3 times in the younger age group, but as the age group increases, this gap decreases. So some silent features, how we differ from our Western counterparts. The rates of CAD are almost 2 to 4 times higher as compared to our Western counterpart, whether it is prevalence, incidence, or hospitalization. The disability adjusted lifespan years are almost 3 times higher as compared to our developed counterparts. Usually, the age of onset is 5 to 10 years earlier as compared to the Western countries. The median age of first MI is 10 years earlier, and the median age in our country is around 53 years. And the incidence of the young MI less than 45 years is 5 to 10 times. And even the very young MI, which is in the age group of less than 30 years, is quite common in Asian countries. It is 3 to 4 times higher than white Americans, 6 times higher than the Chinese, and 10 times higher than the native British. So in nutshell, it is quite higher as compared to other Western counterparts because of higher proportion of unstable and vulnerable plaques. The severity of the coronary artery disease is also differ from our Western counterpart. Triple vessel disease is common even in young and premenopausal women. The MI, the territory of the MI is larger as compared to the Western counterpart, and the complications. The rates of reinfarction are also 3 times. Mortality rate is also around 2 times than the other countries. There is higher prevalence of glucose intolerance in the Asians, but the conventional risk factors like hypertension, obesity, and dyslipidemia are less than the Western counterpart. This is quite surprising. So there are some other risk factors which interplay pathophysiology of CAD in Indian counterpart as compared to the developed countries. The total cholesterol levels are similar or lower than the whites, but higher than other Asians in Indian population. So when we come at a conventional risk factors, when we compare conventional risk factors from our population to Western counterparts, we have still twofold higher rates of any event, even after adjusting the rate of conventional risk factors, which determines that we should have a lower threshold for intervention and even a lower threshold for primary prevention. Some risk factors like lipoprotein A and fibrinogen are at higher levels in Asian population. The HDL is on the lower side, and the component of LDL, that is small dense LDL, is higher as compared to the other populations. So coming to risk factors of CAD, we can categorize them into 2 groups. Either they are modifiable or non-modifiable. Non-modifiable are age, gender, genetic risk factors, race and ethnicity. Modifiable are hypertension, smoking, diabetes, physical inactivity, obesity, dyslipidemia. So we have to put more stress on modifiable risk factors so we can alter the natural history of CAD. So this was a study long back in 2004, Interheart Study, which has studied a large population in 52 countries and studied all modifiable risk factors. They have studied these 9 risk factors and correlated. So in the first 6 risk factors, that is abnormal lipids, smoking, hypertension, diabetes, obesity, and psychosocial factors like stress, the odds ratio of developing CAD is higher, and population who consume good amount of fruits and vegetable, moderate amount of alcohol intake, and regular physical activity, the odds ratio comes down. So these are modifiable risk factors for CAD. So first, coming to smoking, it is a leading preventable cause of CAD. Almost 1/3 of the CAD deaths are due to smoking. India has more than 100 million smokers, second after China. So coming to definitions of smoking, which you must have read in your PSM classes, the current smoker who has smoked more than 100 cigarettes in their lifetime and has smoked in the last 28 days. Ex-smoker who has smoked more than 100 cigarettes in lifetime but has not smoked in last 28 days. And never smoker is someone who has not smoked greater than 100 cigarettes. So this is just from Viva point of view. So how smoking affects? Smoking almost doubles the incidence of coronary heart disease and increase mortality by 5 times. Risk increases with the age and increases with the number of cigarettes smoked. Even light smokers and smokers who do not inhale have high incidence of MI and death. There is one more pathophysiology which acts in smokers. There is increased prevalence of coronary spasm, and the threshold for ventricular arrhythmias is also reduced. Patients who continue to smoke even after a MI or CABG have more risk factors of developing a recurrent MI or adverse events. Even passive smoking can lead to endothelial dysfunction in the coronary circulation and increases the risk of future events. A smoker almost loses a decade of life as compared to a person who never smoked. Even in premenopausal women who smoke, the privilege of protection against CAD is lost, and it acts synergistically with OC pills at the risk of premature CAD, stroke, and venous thromboembolism. So how smoking leads to coronary artery disease? Smoking leads to increased inflammation and platelet aggregation. There is alteration in the endothelium derived fibrinolytic and antithrombotic factors. Inflammatory markers like CRP, soluble intracellular adhesion molecule 1, fibrinogen, homocysteine are all increased in smokers. It also promotes insulin resistance and premature atherosclerosis. There is reduction in myocardial oxygen supply. Smoking the nicotine also leads to increased sympathetic activity on nicotinic receptors, which leads to increase in blood pressure, heart rate, increased sympathetic tone, which has unfavorable effect. So these are the various mechanisms how smoking leads to coronary artery disease. So the people who quit smoking or reduce, they reduce the event rate by almost 50% within first 2 years. And the maximum benefit is seen in initial few months. And the risk of coronary heart disease falls substantially within 1 to 2 years, and the risk equals to a never smoker in 3 to 5 years. So coming to a second major risk factor, hypertension. It is one of the major risk factor for CAD. If we go by data, almost we have 28% of our urban population who is hypertensive. So it's a very huge number. Death from both coronary heart disease increases progressively as the BP goes above 150 mm systolic and 70 mm diastolic. Every 20 mm increase in systolic and 10 mm increase in diastolic doubles the risk of cardiovascular disease, meaning all stroke, MI, TIAs, everything. Even if we compare a pre-hypertensive as compared to a normotensive individual, the risk is higher in a pre-hypertensive. Below the age of 45, usually males are predominant in hypertension. In the group of 45 to 65, the incidence equalizes, and after 65 years, the BP tends to shoot up in females more as compared to the males. So if we control hypertension in an adult, if it is better controlled, then we can prevent almost 56% of the events. Almost half of the events can be prevented. Hypertension also leads to CKD, and it is also a component of obesity, metabolic syndrome, and enhances the risk in diabetes. Even if we come to white coat hypertension, the people who have elevated blood pressures only within office and normal blood pressure at home, or masked hypertension, elevated blood pressure at home and normal at office, vice versa. Both of them are at increased risk of coronary artery disease and future vascular events as compared to a normotensive individual. So coming to third major risk factor, which is dyslipidemia, lipid abnormalities. Low density lipoprotein has been linked to cardiovascular disease, MI, stroke, TIAs, everything from long time. LDL, especially the small dense LDL, is increased in diabetics. LDL is increased in smokers. And small dense LDL with a low level of HDL leads to atherosclerosis, increased inflammation, and increased cardiovascular risk. With every 1 millimole reduction in LDL, that is 38 milligram of LDL, there is almost 22% of the reduction in vascular events and 10% of the reduction in mortality. So by reducing 38 milligram of LDL in a patients who are at risk, we can prevent 1 out of 10 deaths. Higher level of HDL appears to be cardioprotective, and lifestyles such as lower BMI, moderate alcohol intake, estrogen level, that is in premenopausal women, avoidance of smoking and physical activity increases the HDL. So the fourth risk factor, metabolic syndrome. So metabolic syndrome is a basket comprising of many risk factors. The basic pathophysiology behind the metabolic syndrome is insulin resistance. And insulin resistance promotes atherosclerosis even if the patient is a non-diabetic. So metabolic syndrome is a cluster of glucose intolerance, hyperinsulinemia, accompanied by dyslipidemia, hypertension, and obesity. So how diabetes affects our vascular tree? Diabetes leads to endothelial vasomotor dysfunction. The endothelium is dysfunction, it cannot vasodilate with the endothelium derived nitric oxide. Diabetics are having a diabetic dyslipidemia, which is a triad of high triglyceride, low HDL, and raised small dense LDL. This is typical for a diabetic patient. There is increased inflammation in diabetics. All inflammatory markers like CRP, vascular endothelial markers, all are increased in diabetics. Even the platelet activation, aggregation, and morphology are disturbed in diabetics. The coagulation pathway and fibrinolytic pathway don't go in concordance. The vascular effects of advanced glycation products. All these diabetics patients with long-standing diabetics will have long-standing advanced glycation products, which will go and adhere on the vascular endothelium and affect the vascular endothelium of coronaries, renal, and other systems. So what are the diagnostic criteria for metabolic syndrome? There are various criteria which have been given by NATP Foundation, International Diabetes Federation, and other Asian. So main 5 things which are there is abdominal obesity, hyperglycemia, that is diabetes or hyperglycemia, hypertriglyceridemia with triglyceride level more than 150, low HDL less than 40 in males and less than 50 in females, elevated blood pressure, or on an antihypertensive. So the cutoff for waist is different for men and women, and cutoff is different for different populations. So what we have to follow in Indians is cutoff for males is more than 90 centimeters and females is more than 80 centimeters, the waist circumference. So must have abdominal obesity and two other risk factors to classify them in metabolic syndrome. So it's a triad combining, it's basically a pentad, any triad, any three risk factors which acts synergistically and increases the risk of coronary artery disease. So now coming to the pathophysiology, most important pathophysiology which affects our coronary artery is atherosclerosis. So acute coronary syndromes, atherosclerosis can lead to obstruction, and there can be two ways how it can manifest. It can manifest either as a stable CAD or as an acute coronary syndrome. In acute coronary syndrome, which are life-threatening events, usually are precipitated by acute thrombosis superimposed on a plaque rupture or plaque erosion. There is a plaque, atherosclerotic plaque, which has either ruptured or eroded and leading to superimposed thrombosis. In stable CAD, there is gradual narrowing of the arteries, which will lead to symptoms like angina. So by far atherosclerosis is the most common, and other non-atherosclerotic etiologies of coronary artery disease are arteritis, which affect medium-sized arteries like polyarteritis nodosa, trauma, dissection, spontaneous coronary artery dissection or dissection in Marfan's, other things, thromboembolism to the coronary arteries, although rare, but it can happen, congenital anomalies like Al-Kappa, cocaine abuse, these can lead to coronary artery disease. So how atherosclerosis happens? It is a chronic and multifocal immunoinflammatory and fibroproliferative disease of medium and large size vessels, which is driven by lipid accumulation. I'll discuss in next slides. So what is the natural progression of CAD? So there are two things which I have already told. Fixed and hardly reversible process that causes gradual luminal narrowing slowly over the decades, atherosclerosis, leading to chronic stable angina. It is a stable disease, gradually narrowing of the arteries. And dynamic, like plaque erosion, plaque rupture leading to thrombosis, leads to acute coronary syndrome. So this is the pathophysiology of atherosclerosis. This is a normal artery. Then initially there is infiltration of the inflammatory leukocytes in the endothelium. Lipids accumulate, leading to fibrofatty stage, lipid-laden macrophages known as foam cells. There is recruitment of more leukocytes in the smooth muscle and migration of the cells, leading to proliferation and inflammation. There now comes the expression of other tissue factors, collagens, matrix degrading proteinases that weakens the fibrous cap of the atheroma. So once the fibrous cap is weak, it can lead to rupture. And once it ruptures, it can lead to thrombosis or non-occlusive atherosclerotic plaques. And coming to the stable disease, increased collagen accumulation rather than tissue factors and matrix degrading proteinases, increased collagen and smooth muscle leading to fibrofatty lesion and calcification leading to fibrocalcific plaque. There can be sometimes superficial erosions in the endothelial layer resulting in thrombosis and complete occlusion of the artery. So how we differentiate a stable plaque from a vulnerable plaque? Stable plaque will lead to chronic stable angina, as we have discussed. It has a thick fibrous cap, lipid core with foam cells, whereas a vulnerable plaque has a thin fibrous cap, less than 65 microns. It has a large necrotic core rather than a lipid core. There is increased inflammation, increased vascular remodeling, increased intraplaque hemorrhage because of new vessels. So the vulnerable plaque can lead to acute coronary events. So sometimes there are some other factors in which coronary thrombosis is not caused by just plaque rupture. There can be other things also which can lead to thrombosis. It can be plaque erosion also. In plaque erosion, usually there is no deeper injury to explain the overlying thrombus over the endothelium, but there are some irregularities on the surface of the plaque. Why a minor plaque erosion can lead to thrombosis? Because there can be some other vulnerable risk factors like hyperglycemia, increased LDL, the fibrinolytic pathway is altered, there is increased tissue factor, increased fibrinogen, increased coagulation factors, the reactivity of platelets is also high, and the depressed fibrinolysis. So these all can lead to even a thrombosis in plaque erosion. A rupture might not be required every time. So how myocardial ischemia happens? It is just a mismatch in supply and demand. So when you have decreased supply because of atherosclerosis, coronary spasm, or decreased O2 carrying capacity of the blood like in severe anemia, or there is increased demand when we have a left ventricular hypertrophy in exertion or in sympathetic stimulation. So what happens in ischemia when there is almost 50% of the stenosis in the coronary arteries? It leads to flow demand mismatch. When the stenosis is increased to 80%, the blood flow at rest may be reduced, which can lead to symptoms like chest pain. Myocardial infarction results from complete coronary artery occlusion once the artery has been occluded for 15 to 20 minutes of severe ischemia. So the infarction process starts in, and the cell death starts from the endocardium to the epicardium in a wave front manner. It spreads from the endocardium to the epicardium, and as the time progresses, the area of infarction increases. So what are the effects of ischemia? When we have a exposure of ischemia, there is mismatch in myocardial oxygen supply and demand. First is the endothelial and microvascular dysfunction, which leads to the subendocardial perfusion. The first thing is to get affected is the endocardial segment. There is altered metabolism, local acidosis. There are abnormalities of ST segment. There are microinfarcts initially, which leads to diastolic dysfunction. Decreased perfusion again will lead to wall motion abnormalities. There will be irregular contractions of the heart, and eventually will lead to systolic dysfunction. So this is how the process goes on from the endothelium to the systolic dysfunction. So what are the clinical manifestations of CAD? It can be either asymptomatic. The ischemia can be asymptomatic. When patient have asymptomatic ischemia, it can either be provoked by exercise or any sympathetic stimulation. Asymptomatic patients may have changes in coronary artery calcification, which can be seen on CT scans, or sometimes they can present directly with cardiomegaly and heart failure because of asymptomatic and chronic damage to the left ventricular, leading to ischemic cardiomyopathy. In symptomatic, it can either be a stable CAD or an unstable CAD. Unstable CAD comprises of spectrum of unstable angina anSTEMI and STEMI. So basically anSTEMI and STEMI are in one group. anSTEMI and unstable angina are in one group, and STEMI is in other group, which is differentiated on the basis of ECG because they have different sort of management. So stable angina. The term angina comes from a Greek word ankone, meaning a strangling sensation, and pectoris refers to chest. So it is a strangling sensation in the center of the chest. The way this person is there in the figure, keeping his fist on the center of the arm, this is known as Levine sign, typical of angina. So what are the classification of chest pain? Either the chest pain can be typical angina, which includes all three factors like substernal chest discomfort of characteristic quality and duration, which is provoked by exertion or emotional stress and relieved with rest or nitrates. Atypical, which has two of the above features, and non-cardiac pain, which doesn't have any of the above features. There can be some variants also, like nocturnal angina, which presents at night, or postprandial angina which is precipitated after meals. Sometimes patient might not present with chest pain or angina, so they can present with other symptoms of myocardial ischemia, also known as angina equivalents. So what are the common angina equivalents? Most common is dyspnea. Others can be nausea, fatigue, faintness. These are more common in elderly and diabetic patients. So how we classify angina, functional classification of angina? There are three scales: the Canadian Cardiovascular Society functional classification, NYHA classification, and the specific activity scale. For your level, I think we'll go with Canadian Cardiovascular Society classification or NYHA. These two are similar. So class 1 is there is no angina with ordinary activity. Angina occurs only with sternus activity. When we come to class 2, angina occurs during ordinary activity like walking uphill, walking rapidly with mild limitation of activities. Class 3 is angina occurs at low level of activity, leads to marked restriction of the activities. And class 4 is angina which can occur at rest or with any level of minimal work. So what are the various presentations of chest pain? Either it can be angina, retrosternal chest pain with burning sensation, heaviness, which can either radiate to left arm, even it can radiate to right arm, shoulders, neck, jaw, epigastrium, usually precipitated by exercise, emotional stress, cold weather. Unstable angina, the angina is there, but it is more severe than angina. Typically less than 20 minutes, lower tolerance for exertion. It can present at rest also. Crescendo pattern can come and go. Acute MI, the chest pain characteristics will be same as angina, but it will be very severe, sudden in onset, usually lasts for more than 20 minutes, and is associated with dyspnea, weakness, nausea, vomiting. Pericarditis comes in the differential diagnosis of chest pain. It's a sharp pleuritic pain which is aggravated by changes in position, and on examination you'll find a pericardial friction rub like a pleural rub. Dissection, it's an excruciating pain. This is defined as the most worst pain of the life between the shoulders, either in the anterior part of the chest or the posterior part. And usually they have some predisposing factors like hypertension, elderly group with connective tissue disorders like Marfan's. And last but not the least is pulmonary embolism, which presents with sudden onset pain and dyspnea. The pain is due to small microemboli leading in the pulmonary circulation leading to infarcts. They can have even also pleuritic pain also, and presents with dyspnea, tachypnea, tachycardia, and signs of right-sided heart failure. You can, in some cases, find some signs of DVT also. So what are the differential diagnoses of chest pain? If we go system by system, cardiovascular disease, other than angina, MI, it can be because of arrhythmias, pericarditis, myocarditis, and dissection. In pulmonary embolism, pleuritic pain, which is most common, and pneumothorax. Skeletal can be any trauma to the rib or musculoskeletal system there. Sometimes GI disorders can also present with chest pain like esophagitis, dysfunctions of the gallbladder and pancreatitis, and sometimes local causes like herpes and other malignant disease of the chest. So what you have to look in physical examination, the physical examination starts with inspection, palpation, percussion, and auscultation. So in chest examination and auscultation, you might find a S4 or a S3. You have to measure the heart rate and blood pressure to find whether the individual is hypertensive or not. We have to look for other sites of atherosclerosis, because if one bed is involved like coronaries, we have to look for other sites like peripheral circulation, any bruit, abdominal aortic aneurysm, carotid artery bruit, and pulses in the distal extremities. Should also look for xanthelasmas, xanthomas, and tendon xanthomas as signs of dyslipidemia. The main purpose of the examination is to exclude non-cardiac causes of chest pain and non-ischemic cardiac disorders, and also to look for potential signs of hemodynamic instabilities which require urgent treatment and signs of LV dysfunction. Thank you. We'll end the class. Any queries, you can mail me. I'll share my mail ID.